Hello class, and welcome to the lecture on the knee. Our objectives are to display an understanding of knee anatomy, discuss biomechanics of the knee and the relationship of the knee, hip, and foot, identify mechanism of injury and signs and symptoms of common knee pathologies, discuss treatment strategies for hip pathologies, and lastly discuss the use of bracing. So looking here, the knees are complicated. We will take a look under the hood today, but I don't know that we'll get as complicated as any gizmos that we'll need for treatment. So the knee anatomy consists of three bones forming two articulations, the tibiofemoral, and the patellofemoral. The largest joint capsule of the body is at the knee. It's divided into four regions and is reinforced by ligaments and tendinous structures. We have four major knee ligaments to provide stability in all three planes. We have a medial and lateral meniscus, and our dynamic stability in three planes is controlled by muscles crossing the joints. We have a high number of multiple or two joint muscles which cross the knee joint. We have at least 24 bursa and several fat pads that provide cushion and friction reduction. Looking here at the meniscus, so we see the medial meniscus on the right-hand side of your screen. It's kind of a larger, more oval or crescent shaped. It's really firmly fixed to the tibia, so it has little motion. It has about 5 millimeters of excursion. Whereas the lateral meniscus, you see it's more circular, kind of C-shaped. It is more mobile. It has about 12 millimeters of motion or excursion. So the movement patterns of the meniscus, and think of the meniscus as dynamic. They're not static structures. They're not just sitting there. They move. They don't move on their own, but they have movement patterns based on what the knee is doing. So as the knee extends, the meniscus is going to anteriorly move or translate. As the knee flexes, it's going to posteriorly translate. So as you squat down, think of the curve of the femoral condyles, how the curve becomes increased. So you're going to get increased pressure per square inch as that curved structure is on the flattened tibia. So what happens is this meniscus bunches up or moves up underneath that so that it provides a lot more cushion for that. I like this picture. It looks like ET or extraterrestrial. We got his large eyes here, which are common for extraterrestrials. We got the mouth here, little fat pads, probably his tongue sticking out, and you see the three bundles of the ACL forms his nose. The PCL is probably some type of head wound there, probably shot by a redneck, I would guess. So the functions of the meniscus are to distribute weight-bearing loads. They increase the contact area and enhance load sharing and shock absorption. They also increase the joint congruency. So again, they're not flat structures. They're wedge-shaped structures, and this reduces the joint contact stress. They limit abnormal motions, and they guide the normal motions. So they also transmit load. 30 to 70% of the load transmitted across the knee joint is by the meniscus. So in extension, about 50% of the load goes across the meniscus, so not as much. So remember, in extension, they flatten out, they move anteriorly. In flexion, they bunch up, and in flexion, they transmit 85 to 90% of the load. So you see that is a huge function of the meniscus and a very important function of the meniscus that we need to be aware of. So the patella is the largest sesamoid bone with the thickest articular cartilage in the body. So if you look at the patella on the back side of it, the undersurface of it, it has very thick cartilage there. So it acts as a lever arm, lengthens the lever arm of the quadriceps. You have medial and lateral facets which articulate with the trochlear groove as the knee flexes and extends. In full extension, the patella moves proximally to the trochlea, and so in full extension, you should have a high degree of mobility of the patella, so you can move it medially, laterally, and it moves quite well, even superiorly and inferiorly. At 30 degrees, it becomes the most prominent, and then it begins to move into the trochlea as the knee flexes, and then it is beyond the groove in full knee flexion and almost disappears. It's kind of hard to find. So knee biomechanics, the knee is a modified hinge joint which primarily flexes and extends, but it's also able to rotate medially and laterally. The medial condyle is larger, requiring the knee to externally rotate to fully extend. So that's your screw home mechanism. In that last 30 degrees of knee extension, you'll see the tibia will externally rotate and lock into place. This allows for greater stability. Then we have to unlock the knee once we lock it. So that's the job of the popliteus muscle, and that's over here to the right. You see the popliteus muscle, kind of a triangular shape that crosses the knee joint, and that's laterally. Here you see the fibula. So in a closed chain position where the tibia is stabilized, it's going to pull the femur laterally and unlock it. But in a open chain situation where the femur is stabilized and the tibia is unlocking, it's going to move the tibia medially. So it's going to unlock it and rotate it medially. Knee biomechanics, the knee's just stuck in the middle, so it's at the mercy of the proximal and distal segments of the kinetic chain. Here's a statement that I ran across last year that I really like. It says you cannot control the knee at the knee. So you control the knee at the hip, you control the knee at the foot. So you look at the influence of the hip. When the hip moves into an adducted position and internally rotated while the foot is planted in a closed chain situation, the femur will change position around the relatively stable patella. So you see this from these MRI pictures. These are a functional MRI. And so you see here where the femur, the trochlear groove, is stable on a stable patella. The patella is still in the same plane in this picture, but now the femur has rotated out from underneath the patella. So you see how the patella stays in the same plane. The patella has not moved, but it is the femur that has shifted and adjusted out from underneath it. This is caused from weakness in the frontal and transverse plane at the hip. And then the influence of the foot. So you see with pronation of the foot, you get internal rotation at the tibia. And so this can also result in internal rotation of the femur as it just continues to follow. Supination can also affect the knee mechanics as well as leg length discrepancy. So let's look at some meniscus injuries. So meniscus injury typically occurs when the knee is flexed and rotated in a closed chain situation. But in older people, once you probably get 50 and above, it can occur in a degenerative situation. I've had a lot of people tell me, I was just kneeling down and I stood up and wham, my meniscus tears. A lot of times we're also learning with these older population degenerative changes, it's just better to leave them alone. I can't tell you how many people have had just a knee scope in which they went in and they trimmed up in the meniscus, and within the following year they're in with a second surgery, which is a knee replacement. It just seems to cascade those people. We used to see those people a lot where they just go in and clean up the knee, and they really did poorly, and we just don't see those anymore. So you can have a longitudinal tear or a bucket handle. You can have a horizontal tear. You can have a radial tear. You can have an oblique or parrot beak. You can see the parrot beak there. And then you can have a root tear where it's actually pulling off of the tibial attachment. And those need to be sewn back down, reattached to the tibia. You don't see those a lot. I've seen more probably in the last 5 years than I had before, in which they attach them back down to the tibia, because remember, it needs to be stable, but it also has to have some dynamic stability to it. So it needs to have that root repaired. So it is vascularized. We used to think it wasn't very vascularized. You see the inner surface is the white area, so you just don't have any vascularization there. So to repair these makes absolutely no sense because they're not going to heal back up. So they'll come in and they'll trim those out. If you have it red-white, again, it's not going to heal from there, so they're going to trim that out. But it's over here in the red that we're going to get healing, so they will repair these up. And so this the thinner area here in the white zone is the contact zone. It is a real important area because, again, this is impacting the load and the stress that's transmitted across the joint. So some studies have shown that you decrease or you take out about a fifth of the meniscus is going to increase your contact forces by as much as 350%, which is then going to lead to osteoarthritis at an early age. And I think that it's only like 10% of the meniscus removed exponentially increases your risk of osteoarthritis later on. So Stein and others did a study in 2010. They compared 42 patients undergoing a meniscus repair to 39 patients that had a partial meniscectomy. And so they followed up at a mean of 8.8 years after the surgery. They specifically evaluated osteoarthritic progress, the loss of knee function, and the influence on sports activities. So 81% of the patients with the repair showed no type of osteoarthritis at the time of the follow-up, whereas 60% of the meniscectomy patients did show arthritic changes. Their functional scores didn't show any difference in the two procedures, but 94% of the meniscus repair patients returned to their previous level of sports activity. Only 44% of the meniscectomy group did. So to me, that's huge. They may, on a day-to-day basis, have no difference, but there's a 50% difference in those two. Almost all the people with a meniscus repair went back to their previous level of sport. And then there was a significant drop in sports activity in the meniscectomy group only. Let's look at some ACL injuries. So a lot of times we see these as non-contact deceleration, where the foot is planted, change the direction, you get the rotary component. Then you have the contact, usually, and that's what the picture here of Carson Palmer at the bottom right. You see the valgus stress on his knee, and I believe he's even wearing a knee brace there. If I remember right, his leg looks bulky there. I think he has a prophylactic knee brace on. These typically are combined. You have an ACL, MCL, medial meniscus, and these have been labeled by Dr. O'Donoghue as the terrible triad, unhappy triad. You'll see the terrible triad of O'Donoghue. He was the first one to recognize and name this. If you have somebody with a grade 3 MCL tear, you automatically are going to assume they have an ACL tear as well. So the ACL cannot be repaired, so they can't just sew that thing back together, the two loose ends. So they have to be reconstructed. You can reconstruct it with a patella tendon, semimembranosus, and gracilis. You can do it with an autograft or an allograft. If you know your football sports, so Carson Palmer here, I don't remember which year this was that he had it with the Bengals, but he had an allograft. And then last football season, 2014, he retore it and has been since returned to play this year. And I can't remember whether he had an allograft or an autograft this last one. So there's a lot of protocols for ACL postoperative management. Pretty much all of them now allow early motion. Full weight bearing, or part weight bearing is tolerated. Full weight bearing, they will brace them for knee support. If to allow the quad to catch up. So our early goals of rehab are to decrease pain and edema. We want full knee extension as soon as we can get it. So we're hammering on these people from the very beginning to get their full knee extension. We want to normalize their gait pattern. We want to regain quad control. We don't want an extension lag. So an extension lag, you'll see them try to do a straight leg raise laying on their back, and the knee will start pulling up, the knee will bend, and then the heel will lift off, and they'll have a lag in their knee as they lift their leg. Advancement will be slowed in the presence of concomitant injury. So meniscus repair, there's some surgeons that do two separate surgeries. They'll do a meniscus repair and they'll do an ACL reconstruction because repairing that meniscus, they need to be non-weight bearing. They'll limit the range of motion 0 to 90. Sometimes if you have multi-ligaments involved, you'll have an MCL repair. Sometimes they will just suture that down to help stabilize it. PCL reconstruction, microfracture, all of these change your rehab. The immobilizer or brace is usually used in the first 1 to 3 weeks, locked out in 0 until you can start gaining control of the quadriceps for normal ambulation. They'll typically begin with straight line jogging at 12 weeks. And then long-term outcomes tend towards early osteoarthritis, especially with concomitant meniscus and chondral damage. You think of the potential damage to the chondral surfaces with such a violent injury, and you typically will have a bone bruise on your MRI, and you got to expect that the chondral surface is damaged there as well. So I think somewhere around 60% will end up with early osteoarthritis with this. Looking at sensitivity and specificity of some of our tests that are commonly done, the anterior drawer is pretty good for ruling in, telling you that it is an ACL, but it's not real good at telling you when it's not, whereas the Lachman does a pretty good job of both. McMurray is really a bad test. I really don't use it much because it is just not sensitive at all and telling you when it's not. So there's a lot of things that can cause pain, reproduce pain, whenever you put them in that rotated in valgus or varus. So a lot of things can cause pain. And then the specificity on it is pretty low. It's pretty much all over the board depending on the study you look at. The Thessaly test there, where you squat down and you rotate off of that planted leg, some studies have shown it's highly sensitive and highly specific, but there's coming into question the reliability of these studies that have shown it to be so specific and sensitive. Let's talk about patellofemoral pain as signs and symptoms. Typically insidious onset, maybe due to a change in training pattern. Typically intermittent pain at onset may later become constant. They usually don't have an effusion or edema. They'll have diffuse anterior knee pain. They may say the pain's underneath my kneecap. This pain's increased with running or jogging, especially jogging. Walking, descending stairs more than ascending stairs, squatting and kneeling. Positive movie house sign is pain or stiffness or with prolonged sitting. And then stiffness and crepitus. Used to be the focus was on the VMO, study by Smith in 2009, concluded that co-contraction or alteration of the lower limb position does not enhance activation of the VMO or of the vastus lateralis. We really should avoid trying to attempt to preferentially activate the VMO because you cannot do it, and it's pretty futile to do. So you see here this picture, she's got her leg turned out doing a leg raise. I used to do all these funky positional exercises trying to get that VMO to fire, and we really can't do it. The effects of hip weakness on patellofemoral pain, that's probably Sinikowski, I'm guessing, and his buddies in 2007 tested for differences in hip strength in collegiate female athletes diagnosed with unilateral patellofemoral pain. They compared that to the contralateral hip and to healthy sport-matched controls. The authors found statistically significant weakness in 4 of the 6 hip muscles tested when compared to the contralateral limb, and global hip weakness compared to age and sport-matched control subjects. So our treatment is to focus proximally at the hip, weakness, control, and form. If they do have stiffness, we know that's likely from a chondral issue. So we don't want to overload the joint, so we want to focus on high repetition, low intensity for optimal stimulus for healing of the articular cartilage to feed and provide nutrition to that articular surface. Remember, the articular surface, the chondral surface, has no vascularity, so it gets its nutrition on the joint side of it. So the more we bathe that joint with the fluid of the knee, the better that's going to become, and it's going to become healthier. So we progress from open chain to closed chain. I really like the Total Gym because you can monitor and raise and lower the height of the Total Gym and advance the weight bearing. So you know about the static Q angle. I think we've discussed this before. We don't really look at a static Q angle. That's really not our issue, but a dynamic Q angle. So you can see how as she steps down, how her Q angle increases here. The pelvis rotates because of weakness. So that's really our focus, is to be able to keep the hip, knee, and foot all in line as she squats down off of the box. So lastly, to brace or not to brace. So we have different types of braces. with different purposes. So we have an immobilizer that just immobilizes the knee in full extension. We'll have a functional or post-op brace here, which is on the right. So that's typically what you'll see him wearing after the surgery. Then we'll have a protective brace. This is going to be a custom fit brace. You see the quarterback here wearing that on his surgically repaired knee. And then we have prophylactic bracing, and you see a lot of our offensive linemen wearing these. So a couple of studies here. Salata in 2010 came out with a conclusion and a statement: prophylactic bracing in American football has not consistently reduced MCL injuries. Remains lack of evidence to support the routine use of prophylactic knee bracing in injured knees. There is limited high-level evidence and bias in the available literature and confounding variables that limit the current literature. So he's saying don't use it. Well, he's not saying don't use it. He's saying just cautiously use it and understand the limitations. And then Petra Simone in 2008, we cannot conclusively advocate or discourage the use of prophylactic knee braces and the prevention of knee injuries in the collegiate football players. So I think that they do a pretty good job of protecting the MCL. I don't think they do a very good job at protecting the ACL. We've had a lineman just this season tear his ACL as a non-contact planted. You can't control the rotational aspect of the knee. And then there's a YouTube video there that you can pull up and watch. And that's our lecture for today. I hope you enjoyed it. See you in class.